Good afternoon, everyone. It is a pleasure for me to welcome you all to this first EDTNA ERCA Virtual DOPPS Symposium. Next slide, please. Next one. Here is thank you, go back, one up. Here is the agenda of the DOPPS Symposium, but first of all, a brief explanation on how this webinar will be run. As participant, you will have restricted rights. You can only see and listen to the presenters and also see how many other participants are joining this online symposium. Communication is possible only via the chat box. If there are questions of general interest, we will ask the speaker to answer them directly after the presentation for everyone. All the other remarks and comments will be sent to the moderator and they will be answered later on. We record the session and save the presentations. The recorded symposium will be available at a later date on the EDTNA ERCA website. Next slide, please. Before starting, I would like to take the opportunity as the president of EDTNA ERCA and on behalf of the executive committee to sincerely say thanks to the DOPPS team for their dedication and commitment with the DOPPS project. We have all seen the excellent result delivered, and it would not be possible to have this success without the hard work of the DOPPS team. Time is running fast, and it is unbelievable that 13 years have flown by since we started our successful collaboration. My sincere thanks to Anna Marti, her team, and of course, Abo Research. Also, we like to acknowledge the ongoing support of our symposium by donations of Amgen Europe. Now, I am delighted to introduce the moderator for this symposium, Dr. Robinson. Dr. Robinson joined Abo Research in 2007 and has been principal investigator of the Dialysis Outcomes and Practice Pattern Study Program since 2009. Dr. Robinson has research expertise in quantitative analysis for observational studies of patients with advanced chronic kidney disease and end-stage kidney disease, including the epidemiology of these conditions, the period of transition to kidney failure, management of complications including anemia, hypertension, and cardiovascular disease, and the effects of policy on clinical practice. Last but not least, he has a high commitment to providing research oversight and mentoring in renal epidemiology to analysts, trainees, and investigators. So, Dr. Robinson, it is a great honor to have you with us, and please, your speech.
Thank you very much, Edita, and thank you again to the EDTNA for the opportunity for us all to present today. Next slide, please. And next slide as well. All right, I would like to give a general thanks to all of the corporate supporters for the DOPPS program, Amgen Europe, as Edita noted, but also other contributors to the global program as noted, and we're really so grateful for their support for our independent scientific work. Next, please. And I have just about 5 minutes or so worth of introductory slides before we'll move into the curriculum and the exciting analyses and results that will be presented. So, we're so fortunate that DOPPS has been in existence now for nearly 25 years, and actually over 20 years, since 1999 in Europe. And our focus from the very start, this is actually a very old slide, but our focus has been on the association of practices with outcomes. What can we do in the clinic, in the dialysis clinic, to improve patient outcomes, with a focus from the very start on quality of life or patient-reported outcomes. This has been a great focus of ours since the very start. Next, please. Next slide. Thank you. And at this point, we're actually in 19 total countries across 4 continents with over 775 clinical sites, over 34,000 patients. Next slide. And indeed, those numbers pertain now to our 3 different studies, in addition to DOPPS, which is in-center hemodialysis, which we'll focus on today. We have companion studies in peritoneal dialysis called PDOPPS, currently in 7 different countries, with which is actually a project in collaboration with the International Society for Peritoneal Dialysis. A lot of input in Europe, in particular from our colleagues in the UK. And in addition, our study called CKDOPPS, which is a study of persons with advanced CKD stage 4 to 5, and as they transition to dialysis. There's so much interest and so much unmet need still for us to understand how to optimize care as patients progress to kidney failure, and indeed optimizing outcomes for those patients and their caregivers. Next slide, please. And indeed, as noted today, we'll focus on our in-center hemodialysis study. A quick project update. We are currently collecting data. This is DOPPS phase 7 here in Europe and worldwide, currently collecting data actively in 10 countries. The startup in Canada and the GCC, the Middle Eastern countries, was delayed because of COVID, but is just about to get underway as well. And then indeed, the DOPPS in-center study will be in 16 countries. So COVID-19 did prompt recruitment holds and generally delays in study operations. These have now been mostly resolved and we're pushing forward very well. I'd like to take a moment just to give a real note of thanks to all of you who've been on the front line of the COVID pandemic and actually put yourselves at some risk as you are dialysis patients who are really just so needy and vulnerable, and so it's just incredible for folks such as you all to have stepped forward and provided them the care that they need at this very, very difficult time. And we in the community overall are so grateful for that. We are actually not presenting any data on COVID today. We are in the process of collecting survey data from our dialysis unit medical directors and our study coordinators, and of course as well clinical data related to patients who may or may not have been infected with COVID over the course of the past few months. We have a collaboration, as noted, with the International Society of Nephrology, and we're actually extending the reach of that survey really worldwide, well beyond the DOPPS countries, to include lower and middle income countries as well as others. So we look forward to collecting those data and getting them out there as soon as possible. Next slide, please. All right, this is just a quick note that our one of our primary outputs is peer-reviewed publications, and we actually have recently been averaging about 20 publications a year. And again, this reflects input from everybody involved with the study, and we're so appreciative for that, with leadership and authorship from really around the world, including a lot of input and leadership from our European colleagues. Next slide, please. And once again, I'd just like to extend a heartfelt thanks to our country investigators, medical directors, site coordinators, CRAs, clinical research associates, and patients for your dedication to the success of the DOPPS program. Next slide. And in particular, just a heartfelt thanks to the EDTNA. As Edita noted, we worked together since 2005. And you have worked along with us to support participating DOPPS study sites. So this really is a joint effort and absolutely dependent on your tremendous input and selfless work towards the study. And in fact, we noted here the very large number of nurse hours entering data at study sites, as well as EDTNA volunteer hours. Next slide. And in particular, I'd like to give a shout out to our country CRA. So we're the country that the study is running and has been running for over 15 years in these 7 countries. And I'd like to thank In the UK, Karen Chalmers, Jenny King. In Belgium, Michael Rodin. In Sweden, Jeanette Wallen. Germany, Martin Schunemann. In Italy, Marissa Pegoraro. In France, Mark Bogart. And in Spain, Ana Marti, as well as Elena Cavero and Rafael Casas. And warm thanks to all of you. Thank you so very much. Next slide. And here you all are all in picture format. So once again, thank you so much. And on to the next slide, please. All right. Well, Adita actually already showed the agenda for today. We have about 20 minutes for each presenter today. And there will be time for 1 to 2 burning questions after each talk. And then we do have time for a panel discussion, about 20 minutes at the very end. So we look forward to that as well. And next slide, please. All right, well, let's move forward then with our first 4 talks. And Marissa Pegoraro will speak first. Marissa has been involved in renal nursing care since the late 1980s. She was the EDTNA ERCA president in 1995, and she founded the first Italian branch of EDTNA ERCA. In 2018, this branch was transformed into the first Italian Renal Nurses Society. And Marissa's professional core activities are chronic disease management, patient empowerment, home hemodialysis training, and assuring appropriate and accurate vascular access management. Marissa has been interested in clinical nursing education, empowering nurses through better knowledge and conscious awareness of our patients and their needs. She has been the DOPPS CRA for Italy since 2005. And Marissa, we're so grateful for all you've done for us. Thank you. Next slide. Great.
Hello, everybody. Yes, it's Marisa from Italy. I'm a dialysis nurse, and I've been working mostly on limited care hemodialysis center. That means in the middle from hospital and home. And I've been enjoying this activity since a while. My presentation will talk about burden of dialysis, health-related quality of life, and employment comparison between peritoneal dialysis and in-center hemodialysis. And those findings come from DOPPS study presented just now. Please, next. We know that the dialysis have a lot of effects on lifestyle and quality of life of our patient, either for PD patient as well as for hemodialysis. The data that we are going to present are thought to provide the possibility to have informed decision from patient about the type of treatment they could choose accordingly to the effects that this treatment can have on their own life. Next, please. Data are coming from observational cohort study of more than 3,000 in-center hemodialysis patients and 2,000 and more than 2,500 PD patients in countries participating in both DOPPS HD and as well as PDOPPS. And those countries are United States, Canada, United Kingdom, Australia, and New Zealand, and Japan. Patients who have been recruited for DOPPS study are offered to fill up a questionnaire. And the same questionnaire has been provided to HD and PD patients. In this questionnaire, there are several questions which investigate physical, mental component score, burden of kidney disease, functional status, and employment. Questions are taken from validated questionnaire, validated tools, as you can see, the kidney disease quality of life, Lawton and Brady combined score, or the CES score for depression. Next, please. For employment, analysis have been limited to patients who are still on a working age time. Patients on each modality were compared in adjusted linear and logistic regression model for each of the patient-reported outcomes. That means that there are some statistical activity behind the data in order to make them comparable. A secondary analysis has been provided to examine the patient subgroup and changes in score over 1 year of time. Next, please. These slides show the flow chart of the study. As you can see, the starting group in PD was quite large, 3,227, and the in-center patient 4,544. But because there were some excluding criteria after this great exclusion, which means patient who has been treated in both one or the other treatment, patient who had a transplant, a previous transplant, patient with dementia, or a vintage of dialysis more than 8 years had been excluded. Therefore, the primary analysis has been made in for the PD group in 2,664 and for the HD group 3,132. After this first part, there will be, and we talk after, the analysis after 1 year. Next slide, please. These are the patient characteristics by modality. As you see, the first column for PD and the second one for HD patient. Concerning the average, the APD group was a bit younger than the HD, and the weight in transplant list was larger on the PD group compared to the in-center. There are also some little differences in coronary artery disease and congestive heart failure, which was a bit larger on the HD group. Concerning nutritional status, they are very much similar, just a little difference in hemoglobin, but not so much. Next, please. Okay, considering the burden of disease, that means how much the people felt disturbed, and the question they were invited to answer was about how much the disease interfere with my life, how much time is too much time spent in dealing with my kidneys, or feeling frustrated for the disease, or feeling like a burden for the family. So they could choose from definitely true or definitely false, and the range of these 5 possible answers make the slide that we see. There will be several slides with the same outfit. You will see in the lower part the countries where the data were gathered. On the lower blue part, the higher burden, in this case, the higher burden of disease, and the more we move towards the yellow area, the lower burden of disease in terms of percentage of patients. So we are talking about burden of disease in this slide, and you see that the larger part is in the medium area. In Japan, there are very little percentage of people who have a lower burden of disease compared to the other countries. And that's something that we will see through some differences because of social setting or mentality or culture of the country. Next, please. Considering the physical component summary, people were asked to evaluate how better they feel when walking, standing up, or perform some physical activities. And still observing these columns, you see each country HD and PD column. you see that physical component, the percentage of people who felt physically fit was not so high. The central line is larger. The PD group show very often a better percentage of patient feeling a bit better. Next, please. Mental component summary. Patients were asked to express their perceptions related to reading, doing calculation, or logistic thinking. Even here, the light blue column are higher than the yellow ones, meaning that the medium generally people felt not very good, but not even so bad. And the data are very similar throughout the countries in this sense. Next, please. Concerning functional status, you see that the yellow columns are quite high, and that means that people generally gave a high score of functional status. It kept my attention Japan, in which the burden of disease was felt quite high from the majority. Instead, functional status was much better. Concerning functional status, people were asked to evaluate how much they need assistance when eating, getting dressed, bathing, or using the toilets, as well as how they could perform normal daily life, like using the telephone, getting places beyond walking distance, or grocery shopping, that means little shops, shopping, preparing meals, doing housework or handmade work, doing laundry or taking medications. That means functional status. And in this slide, the yellow column are quite evident. That means that in general sense, all patients felt quite not so bad. Considering HD and PD, I just drive your attention in the fact that the yellow column on PD are still a bit larger than the HD group. Next, please. Concerning depressive symptoms, same. The blue column are the very negative or worst data, and excuse me, we are in functional status still. Can you do next slide, please? Okay. Depressive symptoms have a larger gray area. That means that people feel not so bad, but even not so bad. They were asked to express how often in the last week they felt depressed, or that everything was going wrong, or they had some restless in sleeping, feeling unhappy or happy, friendly or unfriendly with people, feeling that they enjoy life or they felt sad. And they were asked to say how often in the last week. They rarely, sometime, occasionally, or most of the time. As you can see, depression is somehow present in large, but there are still, the PD group seems to show fewer depressive symptoms compared to the HD in-center HD group. Only in Australia and New Zealand, situation are very much the same. Next, please. Okay, now we will see the data after 1 year. As you see, the blue area, after 1 year, the number of patient questionnaire decreased because people died. Somebody else terminated for other reason, like transplant, for example, or transfer to other center. And a large number also didn't fill up a second patient questionnaire. So that the data coming from 1 year observation are a bit less, 881 for the PD group and 1,338 for the HD group. Next, please. This slide shows mental, physical, and burden score over 1 year. I simply say the diamond in the middle of the colored area is the meaning the medium average. You see that for the mental score, the PD group, the yellow group, has the diamond a bit higher than the medium line. For the physical, after 1 year, the data were a bit worse, but just a little bit. Instead, for the burden of disease data, the diamonds stay on the same line. The amplitude, the surface of the colored area are just meaning the amount of differences on the coming data. And what is interesting is to see that the burden of the burden score didn't change much in 1 year time. Next, please. Concerning employment, the blue column is the HD patient, and the yellow, the PD patient. After 1 year, there were more HD patients who remain unemployed and more PD patients who remain employed. The change between become or employed or unemployed doesn't change in 1 year time. This means that the general position from the starting point didn't change much over 1 year. Next, please. Depressive symptoms. CES of 10, more than 10 or over 10 is the medium level. So it's not the higher, not the lower, it's the medium level. As you see, the yellow column, people who remain less depressed with fewer symptoms are still the yellow column, meaning the PD group, which was feeling less depressed than the other. And on the opposite side, more symptoms of depression were reported by a higher percentage of HD patient. Next, please. Functional status. Functional status in general is reported by a great percentage of people in the higher level. That means a good functional status. The yellow column is still higher than the blue one, meaning that PD patients score better after 1 year. Next, please. Now there will be a couple of slides reporting a general overview of comparison between HD and PD. Next slide, please. These are continuous variables. On your left, considering the vertical column, everything which is on the left side of the vertical columns means the better outcome for PD patient. Though data, the dots and the line and the diamond stays on the right side, means better data for HD patient. You see, it's just take the highs that the left, the dots and diamond and all the colors stay more on the left side, meaning that PD reported better physical, mental, and burden score, except for the Australia and New Zealand patient, in which you see that there is a different position. Next, please. The next one will be binary variables, yes or no, stuff like that. And there will report about employment, depression, and functional status. Also here you see that circle, triangle, and square are on the majority of the data placed on the left side, meaning that PD patients score better data. Still, even for employment and depression, Australia and had a different attitude. Australian people. Thanks. Next, please. These data make me think about, surely, higher score are seen for PD patient than for in-center patient, except for a few countries and few topics. But from a nursing point of view and as a health organization service, I think that there are important care setting and care model differences for PD versus in-center HD patient. Not forgetting that a priori PD is not available for everybody. Next slide, please. I just put here a comparison of my swing of thoughts about the situation, because PD is an home treatment. That means that people treat themselves at home. Instead, so they adhere to their own daily life time and sequences. Instead, in-center HD patient they are expected to adhere to the unit scheme and timetables. In order to go home and to deal with their own treatment, PD patient enter into a pathway of treatment education before, during, and during the training in PD, because they need to be also empowered in order to manage the treatment at home. Instead, for the in-center PD patient, a little percentage of them receive a training education related to their treatment, and they are expected to go into the dialysis very often as a default choice, in the sense that not often and not in every case PD is also offered. PD patients are supported in their autonomy and self-care, and they have dedicated nurses which allow continuity of nursing care and nursing relationship as well. Instead, in-center HD patients are not requested to take care for their treatment, so they are less involved, they are less empowered. Nursing personnel are organized in order to cover dialysis shift, not to be responsible for a single person or group of patients. Next, please. And just in the same remit, next one, please. Okay. As I said, PD is not available, as is not suitable for every patient. Instead, in-center HD is suitable for all, either via a fistula or a central line catheter. PD is not offered in many private centers. That means that not often the patient can choose what type of treatment to have. In-center HD need a great investment in technology and devices, giving also the benefit and the negative aspects of a treatment production chain setting, in my opinion. PD has a limited vintage due to eventual decline in functional or peritoneal membrane. Instead, HD patient benefit from social aspects of in-center HD, having staff present during all the treatment, and sometime meals provided as well. Nursing focus often on technical and organization tasks, and there are high professional skill mix, and often in great cities, high staff turnover as well. Instead, PD patient typically, for the PD patient, the nursing turnover is typically quite low, and the nursing focus on effective and professional personalized relationship. Next, please. For us, it's important to find some scientific data to say that the group are similar but not equal. In 2016, from the EPOC study, supported by Arbor Research, but also by the National Kidney Foundation, patients in CKD, not yet in dialysis, and people who enter recently into PD or HD, were asked to express their feelings, their perception, their experience, answering some questions. It was a qualitative study. And to the question, do you feel that the decision to go into HD or PD was largely your choice? As you see, the majority of HD patients, I mean 47% compared to 3% of PD patients, says that no. The first no is 32% because there was also CKD patients. So let's consider only HD and PD. And no was because they enter into the dialysis in crisis situation, or it was a doctor decision. There was a little number of combined decision. The doctor and patient decide together. And there was a larger number of yes, but there was a weak yes in blue and a strong yes. The strong yes when there was an informed choice and patient took the decision after having the possibility to be informed correctly. They could choose about the treatment who fit best their life and circumstances. Some of them switched from HD to PD, and some of them make the decision on their own research. But there was also quite a large number of weak yes. That means that patient said that it was her choice, but it was only because the type of dialysis, because of the medical condition, they couldn't go into into PD, for example, because of medical condition. Others say that there was a negative effect of PD and they had to switch over HD, or some of them say that it was a default choice, no possibility to choose. Next, please. And when to this patient was said, why, what led you to choose one treatment to the other? You see that the theme for the HD patient, the negative answer was because of possible infection, the fear of infection, and HD was a default choice. Among the yes, medical condition, fear to be infection from PD, and desire to be treated by medical personnel. So that means a sort of security condition. Combined decision, as you see, we mentioned before. For the PD patient, the yes team was the better quality of life, convenience for home dialysis, ability to work and take care of the family. And from the negative, adverse effect. This means that the patient in reality have a different point of view, and the possibility for them to be informed is very important. Next, please. Going to the conclusion, we can say that generally in this study, patients on PD report better quality of life score, lower burden of kidney disease, better functional status, better depression score, and higher employment than do patients receive in HD in center. From other studies, it appears that some of the reason for quality of life differences can also be attributed to basic differences in care setting, home versus in center, for example, lack of PD availability in some facilities, different care pathways, patient empowerment attitude, and nursing model of care and practices. Next, please. So patient selection for dialysis modality depends on many different factors, making it difficult to adequately compare outcomes from in-center HD versus PD patient. Thus, simple and strict comparison should be avoided. However, our findings help to inform current and future patients, and I would say also healthcare worker and nurses in particular, what quality of life is like as experienced by recent patients in DOPPS treated with HD or PD, and how this change can change over 1 year period. And that's all. Next. Thanks for your attention.
Marisa, thank you very much for that wonderful talk. This is such an important area to understand differences in quality of life and maintenance of overall function for PD versus HD. We have a number of questions, but in the interest of time, we'll move on to the next talk now, and we'll pick those up at the very end. And once again, to the audience, please feel free to submit any questions through the chat function. So the next talk, Anna Margie Monroe is a registered general nurse with 45 years of experience, 40 of them as head nurse of the nephrology department at the University Hospital in Valencia, Spain. Anna's roles include university teaching and research. She has presented at national, international meetings and conferences, and has been a member of the editorial board of several journals. Anna is past president of the EDTNA ERCA and past journal editor as well. Anna is project manager for the DOPPS in Europe and lead CRA for the DOPPS in Spain. And Anna, thank you so very much for all your work in leadership of the DOPPS in Europe. Thank you very much. Thanks.
Thank you, Dr. Robinson. This is just a joke for everybody to be aware, to remind to everybody that we are suffering a pandemic, and at least here in Spain, the situation is still quite difficult, and we have to follow the rules of the health authorities. So, good afternoon, everybody. It's a real honor and a pleasure to be part of this webinar and to be part of such a great project as DOPPS. During the next 15 minutes, we'll be talking about how to smooth the transition to end-stage kidney disease in order to improve early dialysis outcomes. Most of the data will be DOPPS data. Next slide, please. I have no conflict of interest, and I'm grateful to Arbor Research and to Dr. Elke Schaffer for this content and research. Next, please. We all understand what smoothing means, but let me remember you the definition. Smooth means to deal successfully with a problem. So smoothing relates to every action done in order to make the transition more friendly. We have to ask ourselves, how do we measure successfully smoothing transition when a patient enters end-stage renal failure? Next, please. For some authors, and certainly for me, starting renal replacement treatment, in other words, dialysis, means the biggest change a person or a patient can experience, or even is able to cope with. From the patient's perspective means life-altering changes. For many younger patients, the end of being able to walk, being away from home 2 times per week, if chemo is the selected choice, and sometimes because of the traveling and the time of the treatment, it means 3 times up to 7 hours out of home, experiencing potential side effects and complication of dialysis, experiencing an improvement of symptoms, realizing the meaning of chronicity, experiencing an increase in dependence and loss of independence. Next, please. And it's hard, it's really hard or even impossible sometimes to separate physical and mental implications. In order to identify no successful transition, these are potential indicators, and these are close monitored within the DOPPS study. Early death rate, hospital admission rate, quality of life during the first year of dialysis. But what are the determinants of these outcomes? Next, please. Yeah. Now we are going to explore the early death. As mentioned, DOPPS has been looking and close monitoring these items since the beginning. In fact, here you can see DOPPS data from 2002 to 2015, which relate to DOPPS 2 to 5 phases. Now we are, as Dr. Robinson mentioned in the introduction, we are in the phase 7 of DOPPS. So countries were ordered by mortality rate at equal or less than 120 days. And the countries analyzed were, as you can see, Australia, New Zealand, Belgium, Canada, France, Germany, Italy, Japan, Sweden, United Kingdom, and United States. Here in this slide, you can see the mortality rate is less than at less than 120 days of starting renal replacement therapy is much higher than at 121, 365 days, and even more than the one at longer than 365, longer than 1 year. So the mortality rate decreases from the 3 months. The first 3 months, we can say that are the crucial months of dialysis. It's important to notice or to point out that this data has been taken from more than 200,000 patients at the participating facilities. So we are talking about a really large number of patients. Next, please. In this slide, you can see this slide shows the overall mortality rate by age at study enrollment. Estimated crude mortality rates by month, overall, and by age, 65 years or younger versus 65 years old and older, and are presented here in this slide. Overall, the mortality rate was highest in the first 2 months of dialysis, then decreased steadily to 180 days and leveled off during the rest of the year. This temporal trend differed appreciably by patient age. The decline in mortality during the first 180 days was substantially greater among patients 60 years old and older, around 53%, than in the younger patient. That was, as you can see, 35%. So the difference is really considerable, from 53 to 35. Next, please. Yes, sometimes we even ask ourselves, was it worth to start renal replacement therapy? I'm sure I'm confident. I would say that every dialysis nurse, any renal nurse, let's say, has any clinician has asked his or herself this question: was it worth? When you have these patients suffering, and also why not spending a lot of resources, but most of all suffering for 2, 3, 5, 6 months. It seems like we can do much better during the first year, and more particularly in those patients older than 65, as they have the highest early death rate. And it's not only the death rate. The death rate is important, of course. What is also, or even equally important, the suffering they go through the first 3 months before dying. That is sometimes is appalling. It's imperative that we work in order to better understanding how to improve dialysis treatment and how to personalize treatment, how to make how to tailor treatment for each patient. Next, please. We ask, no, the previous one, please. Now, next one. Well, it seems like the order is not the proper one. Next one, please. No. Well, previous one is missing, but yeah, one is missing. No problem. Because we ask ourselves, what determines early death on dialysis? Well, so there is a list of aspects: insufficient dialysis preparedness, surgical vascular access, residual kidney function, residual urine volume, adjuvant pharmacological treatment like diuretics, potassium binding agents, acid buffers, anemia treatment, very important, MBD, which is metabolic bone disease and treatment, and then poor or wrong nutrition. More and more important, more and more is the to address properly the nutrition. Sometimes we are spending huge amounts of money, resources, time with the technical aspect of the dialysis, but then the patient is poor knowledge. I mean, the patient is not eating enough or is not eating properly. So, and this list, then we'll see the slide, has been was published only this year. So this data is very recent. So incremental dialysis. The right moment and the right dialysis dose when a patient is starting renal replacement therapy is being discussed in most of the dialysis conferences. Let me remind you that the concept of incremental dialysis has been widely accepted and is part of many publications. Incremental mean progressive. It's the same. Incremental mean progressive. So step by step. So the start of dialysis often happens abruptly, ignoring a longer process of declining kidney function. Now, the previous one, please. Well, some of the slides can mix up. Okay, no problem. Next one, please. No, so previous one. Okay. The start of dialysis often happens abruptly, ignoring a longer process of declining kidney function. A stepped dialysis regime with a scheduled transition from 2 times per week to 3 times per week would represent an effective and safe strategy to standardize incremental hemodialysis in patients with chronic kidney dialysis, transitioning to earlier stage kidney failure. So sometimes, or some people is advocating, some authors are advocating to start with once per week, most of them 2 times per week, and then progressively arrive to 3 times per week. But incremental dialysis regime has its barrier, of course, like everybody, but the incremental certainly has important barriers, which are patient adherence. Patient adherence in some countries, it's a problem. So it's not, when a patient does not feel that he or she needs dialysis, the adherence sometimes it's more difficult. Risk of under dialysis, if we start with 2 times per week, it has to be close monitored. In order to avoid under dialysis, we have to keep only these 2 times per week when we are sure that it's the dose that the patient needs. Increased burden for all dialysis units, not all, no, in some countries, there is a lack or there are not enough dialysis facilities. So if we start with 2 times per week, that means that we will have more patients on dialysis, and not all the countries are in the situation to adapt this or to enter this possibility. And of course, negative financial implication and lack of data. This, as we will see, lack of data. This is something that some authors, as I've said, are advocating, but there is a lack of data. Only, sorry, only last year, a meta-analysis was published in Nephrology, describing 22 cohort studies showing the results of incremental dialysis. Incremental dialysis allows longer preservation of renal kidney function, deferring full dose dialysis by about 1 year in chemo and treatment, with no increase in mortality risk. Larger and adequate studies are needed to confirm these findings. Early this year, a study protocol was published describing the protocol of a randomized multi-center clinical trial. Initiating renal replacement therapy through incremental hemodialysis, the hypothesis is that initiating renal replacement therapy with 2 times per week preserves residual renal function better than with the conventional regime of 3 times per week. In addition, the hypothesis is that maintaining renal function provides beneficial clinical effects, such as better control of anemia, greater removal of medium weight uremic toxins, and better nutritional status and quality of life. This randomized clinical trial compared 2 versus 3 weekly hemodialysis sessions for patients who can maintain a residual urea clearance rate, without excluding a priori patients with severe comorbidities. In their experience, more than 80% of patients who started incremental renal replacement therapy did not suffer from any relevant complication. The dose of dialysis was progressively adjusted as the residual renal function declined. Diuresis in 24 hours is used as a proxy of residual renal function. The transition to more frequent treatment sessions occurs once residual renal function starts to decrease. However, it is essential to determine whether incremental hemodialysis is a safe form of dialysis treatment. Remember the barriers we just mentioned. Next, please. Here you can see the mortality during the first year of dialysis from the United States renal data system, comparing hemo and PD. You all know the problems when comparing, even we make all the adjustments that cannot be compared. Okay. Next, please. Next, quality of life. As in other aspects of care, and most particularly of the renal care field, quality of life comparison in early phases of chemo versus PD has also been analyzed. Here you can see as a sample 2 randomized clinical trials, one from the Netherlands and the other from China. Then we have observational data from different countries, like South Korea, France, United States, Dutch, and well, different, and UK. So, and a new study from DOPPS. DOPPS and PDOPPS collect information annually about quality of life. DOPPS is very focused on quality of life and how the patients feel, and relating the way we work, what we do at the facilities and the results on patients. That is what makes, in my opinion, that is what makes DOPPS really exclusive, let's say, because all the efforts are made in order to make. When facilities doing this have these results, and that is really important. So PD and hemo patients with comparable characteristics were analyzed. There were more than 3,000 PD patients and more than 4,000 hemo patients at baseline. Burden of kidney disease scores were better for PD compared to hemo, with a higher proportion of patients on PD in the lowest burden range compared to those on hemo, depending on the country. The conclusion of this DOPPS study is that compared to hemo patients, PD patients reported a lower burden of kidney disease score, and among survivors remains stable on either PD or hemo over 12 months. This information, when shared with patients choosing a dialysis modality, could result in an increased uptake of PD. We are going to talk about it in a few minutes, but as Marisa has described, the implication of patient choosing the modality treatment, it's a key aspect. in my opinion, again, is going to be more and more important in the next year. Next, please. Well, here you can see what determines quality of life at start of end-stage kidney disease. The pre-dialysis physical care, here we have the list of symptoms: exhaustion, soreness of muscles, faintness or dizziness, numbness in hands or feet, nausea, dyspnea, pruritus, and then physical functioning, residual urine volume, sexual function, and cognitive function. Next, please. Pre-dialysis education, it's a key aspect of quality of life at the start of end-stage kidney disease. This is something that I think, in my experience, we are doing much better for the last, I would say, 5 years. I would say, if not longer. And it's the importance of the pre-dialysis education. In most countries, we have these pre-dialysis clinics with a renal nurse and with a clinician, and sometimes with a nutrition professional, a dietitian, taking care of the pre-dialysis care. And then the results, the outcomes of these patients who have been lucky enough to benefit of this pre-dialysis education, it's really important. And what determines the quality of life? So it's participation in choice of treatment modality. This for me is like it's kind of an obsession. Addressing work status, knowledge of education, literacy about kidney renal treatment, to feel less dependent, empowerment, shared decision making together with staff and relatives. These terms should be more than just buzzwords. I have to admit, I didn't know what buzzwords meant. So I went to the dictionary. I always go to the dictionary, to a normal one. And buzz means trendy or fashionable word. So please, we'll have to change our mind, and we have to make any possible effort in order for these terms not be just buzz words. Next, please. Okay. Empowering patients is quite a challenge for any health discipline, and of course also for renal. Sometimes it's not that easy for patients, and neither for some professionals, to understand that the more patients take the roles and be part of the decision-making process, the better for all of them, for professionals too, because you see better results. Here you can see results from a well-known EPOC renal replacement therapy study, an ancillary DOPPS study. Marisa also has mentioned it. It's really an important study. Deciding which dialysis treatment, it's a big decision, and the professional role should be or must be to inform and assist the patient, answering questions and making sure that he or she is deciding with all the information needed. Quite often, patients ask to decide for them, but that has to be avoided. At the end of the Casablanca film, it said, "Decide for me, my dear." So no, we have to see more than just Casablanca film. We have to open, and the patients, they have to open their minds. Not to forget that in some countries, like for instance Spain, and most of the European countries, it's mandatory. It's mandatory by law to inform patients of the different treatment options, not only in renal, of course, in oncology, in any, and then to help them to decide, but never to decide for them. The decision aid, there are some decision aids, good ones, improve decision-making outcome. Shared decision-making requires that clinicians, that professionals, provide information support deliberation, assesses values and preferences, and reach decisions that align with their patients. Of course, it's to be acknowledged that many personal, familiar, and social aspects are implicated, not only the laboratory values, many aspects, many social aspects, many familiar and different aspects are implicated, and we have to guide the patient. And this study, I think it would be for most of you. I'm sure that you are familiar with this study, but if not, you can go to the DOPPS page, and you can download it and go through it. It's really interesting. Okay, next, please. What else determines quality of life at the start of end-stage kidney disease? Quality of life is a very complex term, and when starting the dialysis, it's influenced by many aspects. Here you can see the dialysis psychosocial care, psychosocial and social support, family and friends, high-quality social interactions, help learning coping strategies, regular follow-up appointments to define common goals, encouragement from the dialysis staff, and mental preparedness. It takes time to adjust to new circumstances. And it's not only this 35 in the best situation clinic visit. And then, well, we have to decide. It can never be decided in one visit. Never, never. It's just impossible. We need more than one visit. We need more than one interview. And the patient, the family, they need time to digest the situation. And it's for us, and we feel that for us nurses to help them and to translate the situation into their own situation, and to search and to dig the patient situation and the family status and the family to help them to choose. And this is a professional aspect. Next, please. Okay, this and the two next slides are from a study published back in 2003 by our colleague Donna Mapes, an important member, very important member of the DOPPS team. She investigated whether indicators of health-related quality of life may predict the risk of death and hospitalization among hemodialysis patients treated in 7 countries, taking into account serum albumin concentration and several other risk factors for death and hospitalization. This was a statistically significant trend in the risk of both outcomes to increase. Countries included France, Germany, Italy, Spain, United Kingdom, Japan. It was from DOPPS 1. And important again because the sample size was more than 17,000 patients. This is quite impressive. It's not that easy to find studies with such with samples such big, with the number such large. Next, please. Scores for the 3 components of health-related quality of life were identified: physical, mental, and kidney disease component summary. Complete responses of the health-related quality of life measures were obtained for more than 10,000 patients. Cox models were used to assess associations between health-related quality of life, risk of death, and hospitalization, adjust for multiple socio-demographic variables, comorbidities, and laboratory factors. Next, please. Lower scores for the 3 major components of health-related quality of life were strongly associated with higher risk of death and hospitalization in hemodialysis patients, independent of a series of demographic and comorbid factors. A 10-point lower physical component summary score was associated with higher elevation in the adjusted mortality risk. More research is needed to assess whether intervention to improve quality of life lower this risk among hemodialysis patients. Next, please. Well, as summary, we can say body and mind need time to adjust to dialysis. Transition should be understood as a process phase to generate time for adjustment to changes. Good pre-dialysis care should integrate physical, education, and psychosocial care. Hopefully, We will see more and more psychonephrologists in our unit, as it is the situation in most of the oncology department. And I would say that it's not only psychonephrology, it's important, but it's not always. We have to understand that it has to be the multidisciplinary team. We need dietitians, we need social care, and we need renal nurses, experts in any aspect of the renal care. Because traveling with the patient in order to digest the new situation, going with them hand by hand, it's a very difficult and professional aspect, and it's a quite challenging situation. Next, please. Thank you very much.
Anna, thank you very much. I appreciate all your presentation and also your colorful insights and from your own perspective. This is such a critical time of life for patients with transitioning to kidney failure. And of course, this relates very much to Marissa's earlier discussion on maintenance of quality of life with PE versus HD. So there's a lot of interesting questions that we can touch on and can do so during the panel discussion. In the interest of time, we'll move forward right now to the next speaker. Next slide, please. All right, I have the pleasure to introduce Jenny King, who is a retired registered general nurse with more than 30 years experience in renal nursing and research, mainly through the National Health Service, NHS, as a clinical teacher, researcher, and nurse manager. Jenny has been the lead CRA for DOPPS in the UK since 2004 and absolutely integral and critical to the successes of DOPPS in the UK. So we thank you so much, Jenny.
Thanks very much. Okay, hello everybody. As Dr. Robinson said, I'm Jenny King and I'm speaking to you from lovely Devon. Just had started to rain actually, but it's been a lovely day down here in the UK. Today I'm going to present some work about the international comparisons of prevalence, awareness and treatment of pruritus among persons receiving hemodialysis. And this is using data from the DOPPS. Next, please. Okay, so the first thing I should do really is tell you what pruritus is, to those of you that might not already know. It's described as general itching all over the body, and it's associated with kidney disease. It's poorly understood. There are lots of contributing factors towards it, and as well as seeing it in hemodialysis, it's also seen in patients with pre-CKD stages 3 and 4, and it's thought that uremia then leads on to pruritus. And this research mainly refers to published study, a published work in 2017 by the leading author, Dr. Hugh Rayner, who was the chief investigator of the DOPPS study in the UK for many years. And it was done alongside work from colleagues at Arbor Research. So uremic pruritus in patients on hemodialysis is associated with depression, lower quality of life and mortality. And the objectives today are to report on the prevalence, awareness and treatment of the itching to assess how well this important condition is currently managed internationally. And we're also going to report on patient outcomes noted in newer work. Thank you. Next slide. Okay, so this data was collected via patient questionnaires that the DOPPS participants very kindly completed and returned. And it includes 20 years of data from many patients here from 17 countries, and it was data analysed between 1996 and 2015. And as earlier presenters said, it's a huge amount of data and it's over a very long time, which is the beauty of the DOPPS study. It also includes data from medical directors. This is the principal investigator, the nephrologist in 17 different countries, filling out their practice patterns data from questions that they were asked in the survey. So that's also included. Okay, next slide, please. Okay, so the questionnaire, the question on the questionnaire asked, to what extent were you, the patient, bothered by itchy skin in the last 4 weeks? And this question was asked between DOPPS 1 and DOPPS 5, so that's a huge amount of time and patience. And here we can see the answers at the bottom here in each phase, how they compared. What we can see is that the percentage of patients very much or extremely bothered by itchy skin declined between 1996 and 2015. It was from 28% of people were very much or extremely bothered down to 18%. So there's been a slight improvement over the 20 years in the burden of itching, but it's still a problem. Okay, next slide. Okay. Oh, back one, please. Lovely, thank you. So this slide shows results from the individual countries. This is the 17 countries, I think, in the DOPPS 5. So this is just in one of the later phases. And the main thing really is just to show the variation between the two ends. On the left, we've got the UK showing that the percentage of patients at least moderately bothered by itchy skin ranged, it was 48%. And then down to Germany at the other end, it was 26%. And then all the others somewhere in between. Okay, next slide, please. The nephrologists were also, thank you, the nephrologists were also asked about how much that they saw this problem of itchy skin with their patients. And what is really interesting is that the majority of them, 65% of nephrologists, estimated that this wasn't really a problem. They said that less than 5% of their patients suffered from severe itching, and so we had what we call a nephrologist disconnect. They really underestimated the problem. Okay, next, please. So these next few slides were taken from results of patient questionnaires collected during the later phase of DOPPS 5, and they give the patient characteristics and the extent that patients were bothered by itchy skin in the last 4 weeks. So you can really see there's not too much difference in most of the components, the age, the gender, BMI, etc., between those that were really bothered by itchy skin and those that weren't bothered by it. There's a few things I could just look out. There's hemofiltration. It looks like maybe a few less. The people were more. There were less people on hemodifiltration that were extremely bothered, and the same with hepatitis B and C. But most of the other components are pretty similar. Okay, next slide, please. Now this is quite interesting, I think. PTH, calcium phosphate product, and renal clearance, KT/V, is mistakenly thought to contribute towards itching. If you asked a nephrologist or a nurse or even a patient why they thought they might be getting itching to their skin, they're probably likely to mention one of these three things. Now this is a myth, and it's not supported at all by these findings. Really interesting. Next slide, please. In patient reported measures, they show that those who were more bothered by itchy skin also reported being more bothered by dry skin and having restless sleep. Okay, you can probably think that those would go together. Okay, next slide. And this slide shows how much itchy skin can impact life and interactions with others. So on the left side, there's less effect. On the right side, in the darker blue, there's more effect. So you can see from the top going downwards, being annoyed about your itching, being frustrated about your itching, the appearance of your skin from scratching, feeling depressed about itching, those things at the top. There were many more patients ticked the boxes that was a real issue for them. But all of these things down here make it hard to work, feeling embarrassed on your desire to be with people or how you interact with others. Having itching really affects your life in so many different ways. Okay, next slide, please. Few nephrologists refer their patients on hemodialysis who have itching to dermatology or a specialist to help them. So this is what this slide is showing. So really quite interesting. Next slide, please. Okay, gabapentin. Gabapentin is a drug that's used in hemodialysis patients for itching, but it's actually a licensed drug for use in epilepsy and for neurological and nerve pain. It's not actually licensed for use in itching. So this slide here asked about how many patients were actually being given gabapentin as a first-line treatment. Pregabalin, which is a similar drug to gabapentin, was a second-line treatment. It's very similar. Other treatments, the most common treatment that medical directors get cited for using for itching was things like oral histamines, which are normally given for hay fever and allergies, or topical lotions, creams, potions, that kind of thing, something to rub on your skin. In Japan, they do use a licensed drug. It's called nalfurafine, quite difficult to say. So you can see at the bottom of the slide here, it gives the percentage of patients that had a gabapentin prescription at any time during the DOPPS phase, which was the DOPPS 5, that was 3 years in their follow-up. And the United States used it the most, with 21% having a prescription at some time during those 3 years. But some of them, you can see, Japan obviously didn't, but they were using something else. But Russia didn't give anything at all, Spain very little. So most of the countries not really very much use. Okay, next slide, please. Okay, now I'm keeping my fingers crossed that this is going to work. This is a video it's about 3 minutes, about a lady's experience of using gabapentin, and hopefully you'll find it interesting. Oh, can't hear her. Right, I can't hear her, so maybe you can't either. No, okay. Oh, that's a real shame. Okay, so I'm going to have to tell you what this lady is talking about. So she is describing what it was like when she was first given gabapentin. She was a lady at I think it was at Dr. Rayner's clinic in Birmingham in the UK, and she'd had skin itching for a long time, but fortunately at his site they must have been asking patients about problems like this, and she had very openly told him about her itching. So she was one of the first patients, I think, that he trialed the gabapentin with. So she's talking about the first day when she took it, and she specifically says, well, I took it and I didn't really expect much to happen. I didn't think it was really going to work. So I just took it and I just tried to get on with my day. But she said, I got to the afternoon and then I realized that I hadn't actually scratched. And she was thinking, gosh. Anyway, she went to bed that night and she managed to get off to sleep. She was just completely shocked by it because she hadn't had a good night's sleep. She'd been scratching in the night. She was describing about how she quite often had to leave her bed and move into another bedroom because she couldn't sleep with her husband. And you could really understand from what she talked about how this really impacted on her life. Anyway, the story goes on. She was going to talk about it to say that even over the next few days, it just carried on the same. She did have the odd bit of scratching still. It didn't completely go away, but it really helped her symptoms massively. So she was a really big fan of it. And these are available on, I think it's Vimeo. I think if you look on YouTube, you can probably find both of the videos, one about her talking about the symptoms and then one about when she talked about taking the gabapentin. So I hope that's helped a little bit. Okay. So next slide, please. So just to summarize some of the findings from reported outcomes from newer work about itching, and this is from Sukul et al. And some more Arbor research work. This work hasn't actually been published yet, I don't think, but I thought it was very interesting. This is a list of the outcomes or characteristics of people who describe having itching. And I just thought it was good to add this list in here because some of the things are really very serious. So they're having poor sleep, prolonged scratching, missing dialysis treatments. They're sicker generally than other patients. They're old. It happens to older people, happens to those who dialyze quite often via a line rather than having a fistula. They've also got cardiovascular problems. They suffer with, more depression, which we've heard earlier, a lot of our patients do have anyway. They're probably unemployed. They have slower recovery time after dialysis, and they may well even withdraw from dialysis. So pretty poor picture, really. Okay, and my last slide, please. So in conclusion, we can see from this paper that the prevalence of itching in people on hemodialysis is decreasing, but it still remains underestimated. There are large numbers of patients on hemodialysis with severe itching who do not receive any treatment at all. There is a wide variation in the use of unlicensed medications for the treatment of pruritus, and these data provide a benchmark for initiatives to improve the management of uremic itching. So the take-home message really for us is that there's a clear need for the change of practice patterns to reduce the symptom burden of itch and improve quality of life. And as nurses, what can we do? Well, observe the signs in your patients, be aware of it as a big problem, discuss it with your patient, advise them and refer them for treatment. Okay, thank you very much for listening.
Jenny, thank you very much. Wonderfully presented. And it really does go to show your point about the nephrologist disconnect. So as nephrologists in particular, a lot of us are just not quite getting the point. We may focus on K2-RV and anemia, parathyroid hormone, but the patients care about other things, and itching being front and center to all that. So again, it's work on the part of really nurses and all of us need to do yet more to assure we have that connection personally with patients to hear, listen to what's important to them. So thank you so much, Jenny. We'll move on to our final talk. And just to note, we should be finished with about 10 minutes to go before the top of the hour, and looking forward to discussion amongst panelists at that time. And again, please feel free to submit questions or comments by using the chat function. All right, so the final talk will be given by Michelle Rodin, who became a Belgian nephrology nurse in 1995, currently working at the High Care Hemodialysis Center of the UZ Brussels Hospital Dialysis Department at the BUB University in Brussels. He is EDTNA ERCA brand ambassador for Belgium, has been since 2005, and the DOPPS CRA for Belgium since 2018. Michelle, thank you very much for presenting today.
Thank you, Dr. Robinson, for this nice introduction. My presentation today is entitled Missed Hemodialysis Treatments, International Variations, Predictors and Outcomes in the DOPPS study. Next slide, please. Hemodialysis for treatment of end-stage kidney disease is increasing worldwide and is complex and time-consuming for patients. Typically, hemodialysis is provided thrice weekly for several hours each treatment, which imposes considerable burdens on patients. Sometimes is missing a prescribed hemodialysis treatment considered as one form of non-adherence. Numerous factors have been shown to be related to mistreatments in hemodialysis patients, not all of which may be due to non-adherence per se, including logistic factors like unreliable transportation or long travel times, inclement weather, and whether the hemodialysis session was scheduled for Saturdays or holidays. There is an effect of active medical issues, gastrointestinal upset, vascular access dysfunction, alcohol, drug abuse, chronic pain, and depression, or patients' cultural, religious, or demographic factors. Next slide, please. Missing treatments is potentially modifiable, and if the rate of missed treatments were reduced, could lead to improved patient outcomes. The DOPPS study is an international prospective cohort study of hemodialysis care and outcomes and provides a unique opportunity for evaluation of missed treatments across a diverse set of international healthcare delivery systems. The present international study across 20 countries using DOPPS phase 5 data evaluated the phenomenon of mistreatments in hemodialysis patients and its relationship with patients' characteristics, treatment measures, and clinical and patient-reported outcomes. Next slide, please. Patients were randomly selected to participate in the DOPPS from randomly selected hemodialysis facilities within each country to provide national hemodialysis patient samples. DOPPS 5 data were collected from March 2012 to July 2015 from 11,488 hemodialysis patients, 18 years or older, at 439 hemodialysis facilities in Australia, Belgium, Canada, China, the 6 Gulf Cooperation Council countries, Germany, Italy, Japan, New Zealand, Russia, Spain, Sweden, Turkey, United Kingdom, and the United States. A 5% cutoff was predetermined to identify countries in which missed treatment frequency was sufficiently large to understand factors related to this phenomenon. Next slide, please. The primary measure of interest was whether a hemodialysis patient missed any scheduled hemodialysis treatment in the 4-month period immediately before DOPPS 5 study enrollment that were not due to an hospitalization. As you can see, I put on a red triangle on Belgium. I will come back to those 2.3% later on. Next slide, please. These data were collected from each study site in answering the question, how many dialysis treatments did the patient miss? With response categories of 0, 1, 2 to 3, and 4 or more missed treatments each month. Missed treatments were to be reported by study sites based on each patient's medical record. Next slide, please. These are the same basic data represented in another way. Next slide, please. A patient questionnaire was completed by most patients shortly after the 4-month period when missed treatment information was collected. From the patient questionnaire, the following patient-reported outcomes measures were calculated. Perceived general health, burden of chronic kidney disease quality of life physical component summary, mental component summary scores on a 0 to 100 scale with a higher score indicating better health. 10 items center for epidemiologic studies, depression, scale assessing self-reported symptoms of depression, scored 0 to 30 with a score more than 10 indicating symptoms of possible depression. Patients self-reported on how long it typically takes to travel to their dialysis facility, which was dichotomized as 1 or less hour and more than 1 hour. Information regarding misscheduled hemodialysis treatments during the 4-month baseline period was reported for 87% of 9,731 eligible patients across the 20 study countries. The proportion of patients missing at least one treatment in the 4-month baseline period varied from 20% to 24% in the Gulf Cooperation Council and United States to 2.3% in Belgium and even less than 1% in Italy and Japan. The remaining analyses describing patient characteristics, predictors, and outcomes associated with missing at least one hemodialysis session in the 4-month baseline period were restricted to countries in which 4-month risk for missed treatments exceeded 5%. This is the 5% cutoff. Associations were examined between having one or more missed treatment and patient-reported outcomes, levels of selected laboratory values, mortality, and hospitalizations in models using extensive adjustments for patient case mix and country. Next slide, please. Patients having one or more missed treatment were more likely to have hyperphosphatemia, an increased parathyroid hormone level, a decreased hemoglobin level, and a single pool KT/V of less than 1.2. However, as the cut points show, values for serum potassium, albumin, creatinine, and intradialectic weight loss differed little for patients with versus without one or more missed treatments over 4 months. 5 patients' reported outcomes were examined as continuous variables to determine to what extent these PROs differed for patients with versus without one or more missed treatments over 4 months. Patients with one or more missed treatment reported substantially greater burden of kidney disease, higher mean SES-D scores, poorer perceived general health, and lower MCS scores. Little difference was seen in PCS, pain catastrophizing scores for patients with versus one or more missed treatments. Next slide, please. Cox regression revealed that all-case mortality was 80% higher for patients with versus without one or more missed treatments over 4 months in adjusted survival analysis. This mortality finding was consistent when tested separately in each of 4 countries, with the following hazard ratios of death observed: United States 1.75, Gulf Cooperation Council countries 2.03, Russia 3.8, and in aggregate Australia, New Zealand, Canada, United Kingdom, Sweden, and Turkey at 1.48. The overall mortality association was nearly unchanged when models were additionally adjusted for serum phosphorus, potassium, and intradialectic weight loss values. Similar findings were obtained in sensitivity analysis in which missed treatments were based on those counted in the 4-month immediately following study enrollment, which did not require survival through the entire 4-month period. The relationship of one or more missed treatments over 4 months with all-cause mortality did not appear to substantially differ by particular patient's characteristics when the interactions of age, sex, coronary artery disease, and having an achieved single pool KT/V from less or equal of 1.2 were tested. Compared with patients not missing sessions, hazard ratio for all-cause mortality were 1.58 and 1.84, respectively, for patients who had one or more missed treatment during 1 month versus 2 or more months of the 4-month baseline period. The result suggests a higher mortality rate with increasing number of months with missed treatments. The sample size was inadequate to test this hypothesis in any great detail. A similar pattern was seen when investigating the relationship of total number of missed treatments during these 4 months, with mortality hazard ratios for death of 1.56 and 1.8 respectively for patients having 1 versus 2 or more missed treatments during 4-month baseline period compared with no missed treatments. One of the strongest associations with death the investigators observed of missing 1 or more treatments over 4 months was due to sudden death, cardiac arrest. This could be explained by the excessive cardiovascular burden related to expanded extracellular volume, as well as by changes in electrolyte levels and vascular volume that may occur when exposed to longer intervals between hemodialysis treatments. Next slide, please. As another important outcome, all-cause hospitalization was higher among patients missing 1 or more treatments. Shan et al. Showed that already in 2014 for nearly 45 million outpatient hemodialysis treatments at the US Fresenius hemodialysis facilities from 2005 to 2009. Patients who missed treatments were nearly 4 times more likely to be hospitalized or admitted to an intensive critical care facility and twice as likely to visit the emergency department compared with patients not missing a treatment. Obialo et al. Reported a larger linear increase in subsequent age-adjusted hospitalization with each additional missed treatment that occurred during a study month among more than 15,000 US hemodialysis patients treated at dialysis clinics facilities from January 2007 to June 2008. In the current study, patients who missed 1 or more treatments over 4 months were younger and had shorter dialysis vintage and shorter mean hemodialysis session treatment times compared with patients without 1 or more missed treatments. Regarding the treatment time association, the investigators speculate that patients who accept longer treatments may be more adherent to their treatment than patients receiving shorter hemodialysis treatments. Younger patients may perceive themselves as physically healthier than their older counterparts and thus able to get away with mistreatments. Health literacy also may in part contribute to the perceived misconception by hemodialysis patients that missing a hemodialysis session will not significantly affect their health. The study results indicate that travel time to the hemodialysis facility of more than 1 hour is strongly associated with missed treatments. Patients with private transportation to dialysis had better dialysis attendance than patients relying on public transportation. In Belgium, where I live and work, transportation to hemodialysis facilities is covered almost universally, with travel times to hemodialysis facilities typically being relatively short. Next slide, please. The investigators were very interested to understand what factors may be driving the observed large international differences in mistreatments and have been disappointed during their analysis in not being able to elucidate key factors explaining these differences. Thus, the key factors explaining international mistreatment differences remain to be understood. Ultimately, cultural or environmental differences may play a major role, or other unmeasured factors, maybe, although some mistreatments may be a result of behavioral non-adherence, Non-adherence is commonly observed in many different chronic conditions and can substantially vary across countries, and not necessarily in a consistent pattern across chronic conditions. Some slides ago, there was a red triangle above the percentage of missed hemodialysis treatments in Belgium. As you could see, that then it was only 2.3% compared to the United States, where it was almost 24%. I would like to mention some possible reasons for our lower numbers. Firstly, Belgium has, with its 30,700 square kilometers, you can put it approximately 320 times in the United States. We have 66 main hemodialysis centers completed with 52 satellite units called low care centers. And for those who can count quick, there is a hemodialysis center every 265 square kilometer. In between two centers, there is normally not more than 30 to 35 kilometers. That is approximately 80 to 21 miles. This makes the transportation issue less difficult, except for a major traffic jam once in a while. Secondly, the transportation costs are almost entirely paid by Social Security in Belgium. Patients pay €2.50, is approximately $3 per ride, is maximum €15, $18 a week. Thirdly, except for some main centers on university level, most of the centers keep a very familiar atmosphere to treat the patients. As mean age of my patients for the moment is 75 years old, and most of them live alone, they see the hemodialysis treatment as a way out for their loneliness. Birthdays are special days for the patients. They receive a little gift from the hospital, and most of the time they bring cake or chocolates and champagne for the other patients and the nurses in their dialysis room. Nurses do the tour and serve the patients during the treatment. Tomorrow it's my turn to treat the patients with cake. I am working 35 years on dialysis, so all reasons are valuable. All extra work, I know, but done with pleasure to create a non-hospital ambience during the treatment. Our patients, indeed mostly the elderly, like to come and do not want to miss a treatment. Social contact is important. Maybe it is our more personal contact with the patients that gives us a lower number of missed treatments. Next slide, please. This large international study consistently demonstrates substantially poorer health-related outcomes associated with missing treatments in hemodialysis patients. These outcomes include higher rates of mortality and hospitalization, poorer anemia levels, and higher serum phosphorus and PTH control, poorer dialysis adequacy achievement, poorer MCS scores, and greater likelihood of depression, symptoms, and kidney disease burden. However, the more than 50-fold difference in 4-month missed treatment risk across countries and large variability in missed treatment occurrence across facilities in individual countries strongly suggest that its occurrence is modifiable. Across the 20 DOPPS countries, the United States displayed the highest 4-month missed treatment risk at 24%, compared with less than 1% in Italy and Japan. The current study provides additional insights into specific factors related to missed treatments. Future studies are needed to understand the key factors responsible for the observed large international mistreatment differences and to what extent reducing mistreatments in hemodialysis patients will affect mortality, hospitalization, and not to forget quality of life. Next slide picture, please. No. And it didn't went well. The picture I see on the last slide, normally you would have seen Mrs. Juliette H. and her dialysis colleague, Mrs. Irene M. sharing the 85th birthday of Juliette yesterday. Thank you for your attention.
Michel, thank you. Thank you very much. Yeah, I'm sorry we didn't get to see that picture, but that's wonderful. Yeah, I would note quickly that mistreatments are really strongly linked to mortality, as you demonstrated within these data. I think DOPPS has done a lot to show that and get that message out there. In fact, a lot of the reasons why mortality is still worse in the U.S. compared to elsewhere probably relates to mistreatments. So it's an area of, and it kind of suggests that, you know, again, dialysis patients, if you remember with dialysis, we're giving clearance, but we're not giving a lot of clearance. So there's just not a lot of room to, not a lot of room for skip treatments in terms of general health for patients. So thank you, Michelle. We have a number of questions. We have about 10 minutes to go, and a number of questions for the panelists. I would start, first of all, there was a question to Marissa, or whomever can answer, of course, but actually striking to look at differences in the number of PD patients who are waitlisted for transplantation compared to HD patients waitlisted for transplantation. Any comments on that? I think it was something like 35% of PD patients are waitlisted, whereas only 5% of HD patients are.
Well, if you have the more detailed answer, in my opinion, I believe that PD patients are more exposed to dialysis personal care, individualized care. Therefore, they can access to more information and also to be probably more supported on the pathway to getting into transplant list, because the patient has to perform of diagnostic examination, so it's not easy. And in some countries, in some facility, they organize a specific diagnostic pathway for transplant patient, and in others, this is not done. So this makes the difference. Mm-hmm. But you surely have more inside data for this.
No, not per se. But I think, Marissa, that's a really important point, because sort of a natural reaction is that, well, of course, PD patients tend to be healthier and more motivated, and therefore they are more likely to get listed for transplant. And that is probably true, but I think it's also to understand, just as you really thinking about this, you know, the issues such as access to transplant tend to get lost in the daily hustle and bustle of in-center dialysis. So yeah, there's a lot more for us to do to assure that patients are given true access to alternatives to in-center dialysis. So yeah, thank you. There was another question, and this is actually in response to Jenny's talk on pruritus, and it was a comment on dialysis fluid quality. So patients have no access to the quality of the dialysis fluid that they're dialyzed against. Those who receive online hemodiafiltration may have higher degree of fluid purity. The question is, well, I guess the question actually was whether DOPPS has data related to water systems. So age and components of the water treatment systems, quality of the water, drinking water that supports the treatment systems, chlorine or chlorine-like compounds that may go into water preparation systems. I would note, actually, just in short, the DOPPS does not have data specifically on this, but it is an interesting question, and I think an area that's not particularly well studied. Jenny, any additional thoughts on this? Oh, sorry, Jenny, I think you're muted right now. Jenny, it sounds like you're still muted.
Oh yes, here we are. I'm unmuted now.
Good.
Yeah, it's interesting. Nothing that I really know. I don't really know how to answer this, though, I'm afraid.
Mm-hmm. No, it's a very good point. I think it's generally under investigated. The DOPPS would provide a framework for this for someone to do ancillary investigation of water quality and relate that actually to clinical characteristics and patient-reported outcomes such as pruritus, but we have not done so, and to my understanding, it's not really been done in the broader literature either. I would note that the Japanese tend to have, over many years, have had ultra pure dialysate with very low endotoxin levels. Japanese dialysis patients have much lower degree of inflammation as measured by CRP, and they tend to have somewhat less pruritus as well. But that's an area for additional work. So thank you.
Mm-hmm.
Question for folks, and I was just interested in the era of COVID. For example, Michelle, what's your impression been of the effect of COVID on missed or shortened dialysis treatments?
As far as I know, in Belgium, normally they cannot miss dialysis. They are hospitalized with COVID. Positive patients are hospitalized, and they are taken automatically to what we call the infected area. We have separated rooms for infected patients with several things, so they are dialyzed there by specialized nurses in special guides and in special things. But as far as I know, they will not miss more treatments than they do normally, because we try to hospitalize them as quickly as possible, and then they are treated automatically when they are hospitalized. So there is no loss of treatments.
Well, right, thank you. The other question that has come up is for patients who do not have COVID, has the COVID era led to a change in missed treatments? For example, we were concerned here in the US that patients would be quite afraid of going to the dialysis unit and therefore perhaps more likely to skip treatments. I think that the early data indicate that hasn't happened, fortunately. And in fact, I've heard from some that patients who tend to skip treatments may actually be more likely to come in the COVID era because they want to do everything possible to maintain their health. So any other comments from the panel on skip treatments or the effect on hemodialysis care for non-COVID patients in the COVID era? Yeah. Anna, but you're still on mute. It sounds like.
Yeah, I think that I'm sure, Dr. Robinson, that you remember that in one of the webinars that for COVID DOPPS Arbor Research organized quite a few weeks ago, it was that I found it very interesting. In one of the comments that more than one of the participants made was the problem that they had was just the other way around. That some patients normally they realized that they took paracetamol 30 minutes before entering the dialysis unit in order to shadow the symptoms of COVID. They realized that the temperature of the patient was lower, and that was because of that, because the patients were afraid of being diagnosed as COVID positive and then don't be treated or treated in another section or things like that. But well, missing treatments here in Spain it has never been a problem. But from other colleagues I've been in contact with other countries, it seems like it's not been a problem. Not for positive and for negative COVID patients. Renal patients, they normally feel safe at the facility at the units. So for them they feel safe there. That is my understanding, and having discussed the topic with other colleagues.
Yeah. So interesting, Anna. Yeah, thank you. That's my sense as well. And again, the work that folks have done, the nursing staff has done in particular to support patients in this time has been really remarkable. One quick final question from the audience that we can cover before signing off is what about the impact of COVID on access to home dialysis? What's your impression been of that?
Well, my impression, my personal impression, and again, because I've been involved and I've been running the home chemo program at my hospital, is that it's going to rise. I mean, in fact, the Spanish, both in the Spanish Society of Nephrology and the patient federation here in Spain, they are working in order to rise the number of patients at home, both for PD, but more particularly for hemo with the new machines, the small ones with so, and even they are talking about they are growing a program in order to start elderly home dialysis with the ones for elderly patients with supported by nurses. But my feeling is that it's going to have a positive impact in the home figure.
Well, I may add some.
Please,
experience.
yes.
Yeah.
Please.
Well, home hemo has been a positive solution for those patients who were also under other treatment. One of my home hemo patients just realized that she could access to the oncology treatment that she performed routinely because of her cancer stage. And the oncology clinic was very clear. If she was performing dialysis in hospital, she would have to stop the treatment for a while because of the possibility to spread COVID. Luckily, she was on hemo and she was very, very happy. So,
Okay. Yeah.
Offering some other solution, I think, is important.
Excellent. Marissa, thank you very much.
Indeed.
We're actually just past the top of the hour, so we'll bring things to a close. First of all, just a few quick comments. Thank you once again to our speakers. Thank you to the audience, and thanks so much to the EDTNA. Typically, we have this DOPPS Symposium as a component of the EDTNA Congress annually, and we look forward to doing so again, hopefully in 2021, if life returns closer to normal. And the last comment for the attendees is if you could please complete the survey that will be offered to you as you sign off for the program, that would be much appreciated.
Thank you.
Thank you, everybody, and good evening all.
Yeah.
Bye-bye.
Stay safe and healthy.
Bye. Thank you.
Bye.
Thank you.
Bye-bye, everybody.
Bye.